Hello, everybody. I'm Dr. Sonal Dhawan, and on behalf of SRL Dr. Avinash Phadke Labs, I extend a very warm and hearty welcome to you all this June afternoon. It's been almost 15 months since COVID 19 was first declared a pandemic. With regards to the COVID numbers, according to official data present, India ranks second in the world with 2.8 crore COVID cases, followed by Brazil with 1.67 crore COVID cases. The first position is, however, retained by United States of America with 3.3 crore of COVID cases. As India recovers from the brutal attack of second COVID wave, the medical fraternity faces yet another challenge in the form of an emerging fungal infection known as mucormycosis. So mucormycosis has become an epidemic within a pandemic, which means as compared to pre-COVID times, the number of cases of mucormycosis have increased during the COVID-19 pandemic. Just to tell you the prevalence rate, it was pre-COVID times, the prevalence rate for mucormycosis in India was 0.14 case per 1,000 population. Now, we don't have any such data with regards to the current scenario, but there was a tentative estimate made by a joint monitoring group, which falls under the DGHS, and it says that 20% of all active mucormycosis cases are moderate to severe in nature and may require hospitalization. And from these 20% cases, 1 in 500 cases or 1 in 1,000 cases may develop mucormycosis. Let me throw a few numbers at you. As per the data available on 30th May 2021, India has so far recorded 11,717 mucormycosis cases so far, and states like Gujarat, Maharashtra, Andhra Pradesh, MP, and UP, they are logging in the maximum number of mucormycosis cases. Our own state of Maharashtra accounts for 20% of active mucormycosis cases of India. Another point worth considering is mucormycosis a recent phenomena? To answer to this question, let me tell you, there was a study across 16 institutions between September to December 2020, and it was noticed that the number of mucormycosis cases rose by 2.5 times. From December onwards, there has been a palpable rise in the number of mucormycosis cases in India. So we can say technically mucormycosis is not a recent phenomena, but it is one that is many, many months old. It was only because of the second wave of COVID, I would like to say, that mucormycosis started bursting at the seams, which is why on the 9th of May 2021, ICMR, along with the Ministry of Health, issued an evidence-based advisory for mucormycosis, stating that mucormycosis, if left untreated, can turn fatal. To know more about this intriguing fungal infection, we have with us our first speaker, Dr. Jafferhusein Sura, a renowned ENT specialist attached with prestigious hospitals like Prince Ali Khan, Masina Hospital, Saifi Hospital, Apollo Spectra, and many more. He practices at Sura ENT Center at Opera House. He will be telling us more about the clinical aspect of this disease. Over to you, Dr. Sura.
Good afternoon, everyone. Thank you, Dr. Sonal, for the introduction. And is my screen visible?
Yeah.
Okay.
Yes, it is. Yes.
Okay, great. So let's start now. So what is mucormycosis and what it's about? Let's start with that. So mucormycosis is a disease that is basically a fungal infection caused by the mucorales species. There is Rhizopus, Absidia, Mucor, Aspergillus within this. And why is it called black fungus? That's the colloquial term that has been given to this disease. Black fungus means that the tissues in this disease become black in color. Black means it gets necrosed. There is less blood supply because the fungus is angioinvasive. It invades the blood vessels, causes a lack of blood flow to the tissue. It causes the tissue to die and turn into a black color. It is well demarcated from healthy tissue and it's hence called black fungus. It's not a very relevant term, but it is become popular by the media. As Dr. Sonal said, it is not a new disease. This disease has been there for quite some time. We've been dealing with it since the past. Every ENT student who gets into his post graduation knows that he has to deal with this. He does deal with it on a daily basis. But why is it coming up right now? The number, as Dr. Sonal again said, has increased 2.5 times than normal since December, which is significant. We were dealing with maybe 2 to 3 cases every 6 months in the previous period before COVID hit us. Now we are seeing the cases coming up daily. It is coming to our attention daily that, oh, this patient has some eye involvement, another patient has some nasal involvement, some cheek involvement. We are getting inquiries daily on a daily basis, which is significant, which is a significant increase in the number. So again, why is it coming up right now? Basically, fungal infections, mucormycosis, any fungal infection is an opportunistic infection. It attacks those who have a reduced immunity. Immunocompromised status is very important for fungal infections. So, what risk factors are present in today's time that have caused these infections to increase exponentially? So, COVID-19 infection itself is an immunosuppressive factor. Patients who have uncontrolled diabetes, they are also at risk. Chronic kidney disease, patients with ongoing chemotherapy, anti-cancer drugs, they are all immunosuppressed. Now, assuming that patients with kidney disease, chemotherapy, uncontrolled diabetes also get COVID infection, and on top of that are given steroid treatment, that will make it a really conducive environment for this fungus to get impacted and grow. So, the theories that have been floating around are immense. They are saying that it is because of uncontrolled diabetes. Well, it is an added risk factor. They're saying because of steroid treatment. Well, steroids are life saving in COVID 19 infection, and we cannot not give it to people. So, that is an added risk factor. Some people are saying that, oh, it's because of industrialized oxygen. Well, industrial oxygen, then it would affect everyone in that particular environment. So, over a period of time, when we study this disease many years later, the epidemiologists would probably conclude that it is a multifactorial disease. So, we come to the point of how it is diagnosed. Firstly, any patient who's had a recent history of COVID-19 infection has a history of nasal symptoms. The symptoms are nasal, ocular, and facial and dental. It could include all of these or only some of these. Patient will have nose block, runny nose, foul smelling nasal discharge, bloody nasal discharge, swelling around the nose. They may have puffiness of the eyes, redness, blurring of vision, diminution of vision, and then facial swelling, facial puffiness, and loose tooth or falling out of teeth even. It generally hits 3 to 4 weeks post the patient has been discharged. So any patient who has these symptoms post COVID within 3 to 4 weeks, we should have a strong clinical suspicion of mucormycosis. Clinically examine the patient. If one sees blackish crusts in the nose, it is pathognomic of this condition. Take those crusts out, send it for microbiological evaluation on a KOH mount. If the KOH mount shows fungal hyphae, which are aseptate fungal hyphae, then you are sure that it is of the mucor species. Get a CT scan done or an MRI done. In today's day, we prefer an MRI with contrast with gadolinium enhancement. So we are able to identify the characteristic feature of a black turbinate on T2 images, which means that there is no enhancement of the turbinate, which means that there is necrosis. A normal sinusitis will show increased enhancement on uh, gadolinium, but in mucor there will be necrosis of tissues with tissue destruction. Lastly, you take a histopathological test. Once you do the treatment, you take a biopsy for histopathology. That will show invasion. Angioinvasion has to be demonstrated for it to be diagnostic of mucor. What is the management of mucormycosis? It is complex. It is a multidisciplinary approach. It requires a multidisciplinary approach. We have surgery, there is medication, but surgery is not curative in this condition. Medication is curative since it's an infection. Why does surgery play a really, really big part in this condition? And which all are the team members required? We need a physician, a nephrologist, an ophthalmologist, either an ENT or oromaxillofacial surgeon, and the people who are helpful in diagnosing it and telling us which drugs to give this patient, the microbiologist and the pathologist. So, what is the goal of surgery in mucormycosis treatment? The goal of surgery for mucormycosis is simply debulking the disease, reducing the disease load. When there is so much extensive necrosis in the nose and spreading further, there is a chance that the drug of choice will not reach the desired area because of angioinvasion and blockage of the vessels. So we have to debride all of this disease, remove all of it, and then only will the drug be effective. So what is the approach that is preferred? Do we do endoscopic or open? That depends on where the disease is located. If we have, let's say, a disease limited to the sinuses, ethmoid, maxillary sinus, one can easily do it endoscopically and remove it. When there is disease spread further that involves the eye and requires an open approach, one can take it out completely along with doing a maxillectomy. If there is disease involving only the palate, only the alveolus, then of course again we would prefer an open approach rather than endoscopic approach. Though disease is better cleared posteriorly with a combined approach when it passes into the sphenopalatine, pterygomaxillary fissure, and the infratemporal fossa. A combined approach is desirable. We come to the next question in surgery is the eye to be removed or should we preserve the eye? Again, here there are two schools of thought. When the disease is just abutting the eye and causing an inflammatory swelling in the eye, if we just remove the disease itself, that is abutting the lamina papyraceae, most of the symptoms of the eye will resolve. But once it has invaded the periorbita and there's involvement of the muscles, involvement of the fat of the orbit, it is better to remove it completely, remove the disease completely, and preserve the eyeball because it gives the patient a cosmetic appearance rather than having no eye there. But another school of thought says that it's better to remove the eye, including the globe completely, because otherwise it will result in painful phthisis bulbi. But either which ways, tackling the disease of the eye is essential because if we leave that unchecked, it can spread along the optic nerve to the brain, causing osteomyelitis of the skull base and leading to infarcts and further complications. So once the disease has involved the eye, we have to remove the eye or at least the disease in the orbit. What is the end point of surgery? The end point of surgery is basically to ensure that there is significant amount of bleeding from all the diseased areas. If there is bleeding, it means blood supply has been restored. That means that all the dead tissue has been removed and now your drug will work because it will reach the area and there is significant penetration. So what's the drug of choice? What is the medication available for amphotericin B? For mucormycosis, sorry. So the drug of choice is amphotericin B. There are three preparations available currently in the market. One is liposomal amphotericin B, which is the drug of choice. It has the least toxicity. It has the least toxicity, but still very toxic. One has to keep on monitoring the kidney function tests daily and monitoring the patient's condition, the potassium levels, etc. We have a liposomal, we have an emulsion of amphotericin B, which is less available. And the last is plain deoxycholate amphotericin B, which is the most toxic and is not preferred today if liposomal is available. The total dose desirable to give a patient of liposomal is 3 to 5 grams cumulatively, whereas plain deoxycholate we can give up to 3 grams a day, 3 grams in total. These drugs are toxic and cause significant side effects to the patient, hence, they require constant monitoring. Another alternative available to patients who have compromised renal function or in those who are amphotericin B is contraindicated or allergic to amphotericin B is posaconazole, part of the azole group. You can give it in tablet or syrup form. Again, the doses are different according to different groups, but the tablet form is better than the syrup form. We are currently using tablet posaconazole 300 milligrams twice a day on day 1, thereafter 300 milligrams a day for at least 14 to 21 days. Another newer drug is isavuconazole, available in the market as Cresemba. These are really expensive medications and are definitely not preferred if amphotericin B is available, and should be used only if amphotericin B is not contraindicated. So again, as I said, we have to monitor the patient's function, the renal function. This will help us adjust the amphotericin B dose and make sure the patient is able to tolerate the medication. Another monitoring point is the C-reactive protein, or the CRP, that is important in patients that don't have other diseases and are not compromised by overall ill health. If we monitor the C-reactive protein, we are easily able to tell whether the disease load is reducing within the patient. So serial monitoring of CRP gives us an idea on its own whether the patient is improving in toto, or the patient is stable, or is worsening. Repeat imaging. Repeat imaging for this condition would be in the form of an MRI. Again, after the disease process has been cleared after surgery, maybe 5 to 7 days after giving amphotericin B, you can do a repeat imaging to evaluate whether the disease process is still active or has been completely cleared. Lastly, we do a repeat endoscopy. Serial endoscopies are done after the surgery to evaluate whether there is only crusting or there is formation of further necrosis and spread of the disease. Sometimes early endoscopy daily for the patient may help pick up disease which will not be picked up on radiology initially. So after we've done with the diagnosis, how you find out what the disease is, what does the disease do, it's really a point that everybody asks us, okay, doctor, now that you've told us what the disease is, what it does, how you treat it, what surgery is involved, but why can't we just prevent it? Unfortunately, there is no way to predict which patient will develop this condition. We have so many cases where the patient is completely healthy. They've just taken a few days of steroids and they've developed nasal symptoms 3 to 4 weeks later. And then we have patients who are severely ill, been in the ICU for a month due to COVID-19 infection. They've been given steroids, and there is no evidence of any mucor infection post 3 to 4 weeks, even 6 months later. So there is no prediction as to which patient will develop this disease. Since there is no predictive factors, then we are unable to tell which are preventive factors. The only things that we can do is do proper surveillance of patients of COVID-19 infection, in addition to the other group of patients which were already immunocompromised. You have to control sugars. You have to do endoscopy regularly, probably weekly post the discharge of the patient. Patients can be advised to do saline nasal irrigation or use a slightly dilute solution of betadine to clean the nose on a daily basis. These are though not proven yet to be effective. These are just general advisories. They are not definite guidelines. As you know, there is no harm in cleaning the nose, keeping the nose clean, and doing an endoscopy to be sure and pick up the disease early. Most importantly, we ask patients to watch for symptoms, because once the disease enters the nasal cavity, if you just ignore it and say this could be a minor cold, etc., and your sugars are uncontrolled, it is possible that it may spread super fast into the eye, cause eye symptoms, and once that is there, then the prognosis becomes very difficult. So Dr. Sonal said one thing, that it is a fatal condition. A fungal infection being a fatal condition is rare, but yes, it is true. The 3 month survival rate is only 50%, and if we catch this early, we can definitely be curing patients of this. But again, the point is we need to catch it early. Now, God forbid you have developed this condition. The first and foremost thing that I advise you is do not panic. Essentially, believe whatever your doctor is telling you. Do not believe whatever you hear on WhatsApp and Google. Talk to your doctor for advice. Get your treatment sorted fast and ensure that you get timely intervention. But do not panic and have faith in your treating doctors. Thank you so much. Dr. Sonal, I'll hand over to you again.
Thank you very much, Dr. Sura, for such an informative talk. I think we can take up a few questions.
Yeah.
One says, how does one diagnose mucormycosis? I think that would be handled by Dr. Pooja, because as it is, she would be talking about the diagnostics diagnostic techniques for mucormycosis.
Yeah. Sure.
But clinically, yes, we can have your point of view about that. I mean, if you would like to answer that.
Yeah. So clinically, we can diagnose mucormycosis by just having a look at the patient, The characteristic black crusts formed in the nose with destruction of tissue, along with symptoms that are out of proportion once you look at the patient. These things give us an idea, especially when there is eye involvement. That gives us a more definitive clinical suspicion that this could be mucor. And then we take a sample and send it across to the lab and hope that the lab person can give us a diagnosis. Any other questions? Yeah.
All right. There's another question which says, hi doctor, is PCR the right test for mucor? So I think that will be better answered by Dr. Pooja.
Yes.
Because she'll be able to explain that.
Yes.
All right. And let's see how many more questions are there. If there are any, I'll let you know, Dr. Sura, and we can always have a Q&A answer session at the end of the PPT. Let me introduce our next speaker. This is Dr. Pooja Gumaste, our very own consultant and HOD microbiology, SRL Dr. Avinash Phadke Labs. Over to you, Dr. Pooja.
Good afternoon, everybody. Heartfelt thanks to all of you to make time to register and attend for the event. We'll not waste much of time. We'll just start the presentation. Is it visible, Dr. Sonal?
Yes, it is. It is. Pooja, you can continue. It is. No, we can hear you. We can see you.
Thank you. All right.
Thank you.
Good afternoon, everybody. So today's topic is mucormycosis, an emerging challenge with COVID-19. So when we were just coming across the second wave, we suddenly had a surge in the cases of mucormycosis. So let's understand what is the hype about, why is the disease of such a big concern that it has been declared notifiable. So a little bit of introduction. It was also called zygomycosis. The trait of this fungal infection is that it is angioinvasive. It has a particular affinity to go and bind to the endothelium. So you will see extensive infarct and necrosis in these diseases. So clinically also you will find eschars. In histopathology you will find necrosis. So the characteristics of this disease are tissue infarct and necrosis. The diagnosis is an emergency because delaying it will affect the outcome. The disease is rapidly progressing in most cases. Very rarely it is chronic. Usually they are the cutaneous cases which are the chronic ones. The disease is mainly community acquired, though few cases, 5 to 8% can be nosocomial. The clinical presentations are classified on the basis of anatomical localization. So the agents, the fungi, which cause mucormycosis, belong to a category of fungus which are called mucorales. As discussed, they have an intrinsic ability to invade blood vessels. Now, where is this fungi found? It is ubiquitous. It is around us. It is in the air that we breathe. It is in the food. It is in decaying organic material. It is everywhere. So they are frequent pathogens of plants. We will say that they are there in the atmosphere everywhere. When we say ubiquitous, it is spread across the environment. The mode of infection. So we'll quickly go through. So main mode of infection is inhaled spore in a normal immunocompetent individual. These spores are blocked. They are not allowed to proliferate because of the neutrophils and granulocytes will go there and they will block the proliferation. But in a list of situations which are immunocompromised, neutropenia, steroids, high sugars, a lot of diseases, this fungal proliferation will go undetected. It will go ahead, cause angioinvasion, necrosis, and then the main disease itself. These are the common, so fungi that we discussed are mucorales. They have a lot of fungus in the whole group. But if you see, these are the common names that you will hear: Rhizopus erisis, Rhizopus microsporus, mucor, rhizomucor, Lichthemia. These are the most commonly involved. The rest that you are seeing down, Epiphyomyces, Cunninghamella, they are all mainly involved in cutaneous diseases or isolated renal diseases. Now, it is very important as a clinician and as a patient also to monitor yourself. So, these are the clinical types. As we said, they are categorized as per the anatomical location: rhinocerebral, pulmonary, cutaneous, gastrointestinal, disseminated, isolated, renal, and isolated cerebral. So, it is always important to know that which clinical type is having some common clinical association. So when you have a diabetic patient with or without ketoacidosis, you should mainly suspect it to be rhinocerebral. But if you have a patient who is having intravenous drug abuse, then you should suspect that he will have an isolated cerebral. So you should monitor accordingly. You have a patient who has a hematological malignancy, who has neutropenias, who is on long-term steroid therapy. In such cases, you should expect them to have a pulmonary and a disseminated lesion. So this sort of association help us to monitor better. And there is a very particular thing which is gastrointestinal mucormycosis, which is most commonly seen in premature infants. It has a association with neonatal necrotizing gastroenterocolitis. So based on the clinical situation, you know how you can prevent and how you can diagnose it faster. So this sort of association list and understanding that each type is associated with some factor will help us identify the cases faster. The clinical manifestations, they are again site specific. We will not go through all of them, but at least let's go through the rhinocerebral one, which is the most common. We could easily say that more than 95% cases are of rhinocerebral origin. So any patient having facial pain, lethargy, loss of vision, having brownish discharge from the nose, a black eschar on the palate, periorbital cellulitis means a swelling around your eye, ophthalmoplegia, having a restriction in motion, ptosis, eyelid being drooping down, proptosis, eyes becoming very like protruding, and dysfunction of cranial nerves. So these are the symptoms that a patient who is discharged post-COVID or who has some hematological malignancy or who is already immunocompromised should be given a list of these symptoms. And they should be advised that in any of these symptoms they should come back and see their clinician. the symptoms are very non-specific, chest pain, dyspnea, hemoptysis. Cutaneous, we are not going to discuss this because this has a very particular history of trauma and burns, and in some cases giving injection through cloth. There are still, we will find, you'll be surprised, but there are still certain rural settings where cases are reported due to the practice that the skin is not disinfected and the injections are given through the cloth itself. So in today's era, we don't expect, but yet it is still there. If you see literature, the most common type is rhinocerebral mucormycosis, followed by cutaneous and pulmonary. So in all studies that have happened in India, these are all pre-COVID studies, and most of them are single-centric studies. So they have all come to a conclusion that mainly it is rhinocerebral, followed by cutaneous or pulmonary, depending on the clinical setting. Now, everybody have, like two of my previous colleagues have already discussed that yes, mucormycosis is not a new entity in India. So I had a little bit of information regarding how was the state before the COVID era. If you see, there was a study, a long-term study done by a very eminent mycologist of our country. In the first decade, he found that the incidence was 12 to 9. In the second phase of the study, which was over a 5-year, he found a 5-year period. He found that the cases were 35 cases a year. And then following that, it was 50 cases a year. This is a single-centric study. In the study, he proved that there is an increasing trend. And at the end of the study, it was sort of proven that mucormycosis is an emerging disease in our country. The prevalence of mucormycosis is 0.14 cases per 1,000 population, meaning that for every 1,000 population, there will be at least probably one case, or say one case per every 1,000 to 2,000 population, which is 80 times higher than other countries. If we see the statistics further, it says that the diabetics, 0.16% of diabetics are going to develop the disease, and 1.2% of renal transplant recipients are going to develop the disease. So when we see this in context, 0.16 of diabetics, then we will use this slide for having a rough idea. So the diabetics in our country in 2011 were 61.3 million, and the estimated rise by 2030 is 101 million. So if we see that 1.16% of this 100 million, then it's a significant number. So we have to see it in a context of the whole thing. So even in pre-COVID era, it was a threat, and after post-COVID, it has become a bigger threat because the population susceptible has increased due to COVID. A lot of studies also showed that mucormycosis was the unmasking disease, meaning those patients were not aware that they had diabetes, and because of mucormycosis, retrospectively they were diagnosed to have mucormycosis. A lot of ICU patients who have a long-term treatment ongoing, they are already given a lot of antibiotics, some are given some antifungals. Later on, such patients also go on and develop invasive fungal infections. In that, invasive aspergillosis is more common, but invasive mucormycosis is also seen. And based on the studies, an estimate of the incidence is between 10 to 12%. Now, all said and done, even if you diagnose and if you start treatment, the mortality is nearly 50%. The disease is very fast spreading, and hence the mortality is very huge. So at all steps, vigilance has a very important role on the part of clinician, on the part of patient, on the part of laboratory person. So, yeah, next slide. If you see, this is just a study again demonstrating the number of cases. All this is pre-COVID single-centric studies. Okay, if you see in a period of 15 years, the cases that they found were 382 registered confirmed cases. The number does not include probable cases. So always probable cases are a little bit more than confirmed cases. So by this we can have an approximate idea that this is a single-centric study saying that from my particular hospital I had 382 cases over a period of 15 years. There is one more study saying I had 184 cases over a period of 10 years. So roughly each center is having 18 cases a year. So that's a big number. Now, current status of mucormycosis. we have seen that suddenly there is a huge increase in mucormycosis cases in patients who have recovered or who are recovering from COVID-19. Apparently, 11,000 documented cases of COVID-19 suffering from mucormycosis are registered. Most of these are rhinocerebral type with Rhizopus cereus as the pathogen. So we all know when we say immunocompromised, it includes a very big list of diseases, but this is just an elaborative list, including everything. But in the current situation, the main factor remains post-COVID immunosuppression. Other than that, we'll just go through it quickly. Diabetes without ketoacidosis, hematological malignancies, neutropenias, hematopoietic stem cell transplant, solid organ transplant, prolonged administration of steroids, iron overload, malnourishment, premature infants, intravenous drug abuse, AIDS, trauma, burns, etc. This study has sort of demarcated as to how many with each risk factor, how many cases were registered. And all the studies consistently said that diabetes mellitus is the single most biggest independent risk factor for developing mucormycosis. So now the question that, why there is a sudden upsurge in mucormycosis post-COVID-19. So these are the probable cases, these are speculations, or let's see how there is no medical evidence for all these cases as of now, but these are the probable causes. One, indiscriminate use of steroids. Two, contaminated masks. Sometimes masks are used, they might not be washed properly, cloth masks we are talking about. Then we have contaminated accessories while administering oxygen to the patients, iron or zinc overload, industrial oxygen versus medical oxygen. So there has been a lot of debate about the topic, and some clinicians and a lot of researchers believe that industrial oxygen causes more damage to mucosal lining. And once the mucosal lining is destructed, the chances of the spores getting access to the internal system is huge. So I'll again clarify, these are all speculations, and evidence-based studies need to be carried out to accept or reject the above. Dr. Sonal has already mentioned that mucormycosis is a notifiable disease. All private hospitals, labs, everybody has to convey these reports to IDSP of the respective state. Also, before COVID itself, the disease was declared as a neglected tropical disease by WHO. So that explains us the gravity of the situation, that mucormycosis is also listed as a neglected tropical disease. Diagnosis, clinical, radiological, Dr. Sura has nicely covered, but just the symptoms. Cranial nerve palsy, diplopia. Diplopia means double vision, seeing two of everything. Sinus pain, proptosis, periorbital swelling, orbital peck syndrome, palatine ulcer. So now, moving on to my core area, microbiology. Instructions for specimen for microscopy and culture. So whenever you're collecting specimens, we have had a lot of questions from a lot of clinicians, how we should send specimen, what specimen we should send. So at the end of the session, you all are going to receive a handout where according to the type of disease, the type of specimen is also mentioned, and also what tests you could do. So we'll just go through this. For microbiological analysis, meaning culture, PCR, and also KOH, we want the specimen to be without formalin. The type of specimens which are desired are nasal scraping or discharge, sinus aspirate, tissue specimen or biopsy from site of lesion. So sometimes we are also receiving a swab. So a swab is not an ideal specimen, but yet we do accept, since in all cases having an invasive procedure to take a specimen is not possible. For pulmonary localization, sputum, bowel, bronchial aspirate are the desired specimens. A transport container has to be sterile, and when you are going to collect a nasal crust, scraping, discharge, the container should be sterile and pre-humidified with a few drops of sterile saline. Ensure early transport to the lab, as mucorales are very sensitive to the environment. Okay. So the main core of diagnosis in lab remains direct microscopy, where we demonstrate large aseptic hyaline hyphae with ribbon-like morphology in the clinical specimens. This test is done using 10% KOH. This slide and henceforth a couple of slides will be having more focus on my lab community who's attending the seminar, the webinar. So we are going to use 10% KOH. The thing that we should be taking care of is that we should not tease or disturb the tissue. The tissue has to maintain the integrity. If you tease or disturb the tissue, the cytoplasm of the mucormycosis will come out and then it will not be able to grow and you will not be able to see the morphology very clearly. To increase the sensitivity, a lot of clinicians also feel that KOH might not be a very sensitive test. And also we have literature to support that yes, 70 to 80% is the sensitivity of KOH in confirmed cases also. So how do we increase the sensitivity? We can increase KOH concentration to 30% in cases of thick or tough specimens. We are not talking about general specimens, but if you have a specimen which is not liquefying or a specimen which is not dissociating, then we can increase the concentration of KOH. We can add brighteners like calcofluor white. Calcofluor white has the capability to go and bind to chitin in the cell wall. And such additions are very useful when you have specimens which are very scanty load. Okay. And one more thing that we practice is we recheck slides on following day or after a few hours. This is again very important for thick specimens because we don't want to give any false negatives. These are some pictures of KOH mount taken at our lab. You can see this lovely aseptate hyphae. This is also mucor. This one is not mucor. I have just shown to show the difference. That mucor hyphae are very thick and aseptate, and these ones are really very thin and filamentous. These are other molds. This is again mucor, aseptate hyphae, nicely arranged ribbon-like random branching scene. Now, when we are having investigations, a lot of times we get a direct request that yes, this is a clinically suspected case of mucormycosis, and we get specimens accordingly. Oh, this is a nasal crash, and then sometimes it is an incidental finding. In this case, we had received the sputum for aerobic culture. Aerobic culture meaning routine bacterial culture, but we could see hyphae-like mucor in the slide, and also it had grown in culture later on. So in such cases, extra vigilance on part of microbiologist will be helpful so that they can go back and tell the clinician that yes, so and so is the finding. In this particular case, the patient had hematological malignancy, and yes, it helped him to start it was not clinically suspected that he might have pulmonary mucormycosis, but in this case, the patient had. Now, this is a case of mixed infection. On the right side, you could see that there are hyphae which are aseptate, classical of mucor, and on the left side you could see they are septate hyphae. So this is a mixed infection. This was also seen on a gram stain. This was also not suspected to be a clinical mucormycosis cases. This was a ICU patient with a double infection. This is the same slide in 10 power. Okay. Now skipping on to histopathology. So this last slide we are getting over with the microscopy part in microbiology. Now there is another aspect where you do histopathology of the specimen received. Again, non-septate hyphae with wide angle branching in thrombosed vessels or sinuses, surrounded by leukocytes or giant cells or both. The stains that we use in histopath are hematoxylin, eosin, GMS. GMS is a very sensitive stain. It goes and binds to the mucor and distinctively shows the fungi. Okay. This is an HNE showing mucor. This is a GMS showing mucor. Skipping on to culture and identification. Culture is when you take the specimen and you allow the fungus to grow on artificial media in a laboratory. So when we get a sterile specimen and you are able to grow mucor, it confirms the diagnosis. The fungi are thermotolerant and they are able to grow at room temperature. They are not very easy to isolate and maintain. As we said that the handling is very important. We have to delicately handle the specimen if you want it to grow. There is low sensitivity of cultures because of grinding or homogenization of tissues sometimes. There are some genera which have very specific requirements like Apophysomices. They can't grow on regular media and with regular supplements. They need a special sort of media. Another reason of not growing cultures could be a recent or ongoing antifungal therapy. Sometimes they start therapy and then they send the specimen. The common media that we use in lab are saboros agar, potato dextrose agar. Now, once you grow the fungi, how do you identify which fungi it is? In our lab and in our settings, we use Maldi-Top, which is a very good tool, and it helps us to identify it up to species level. And there is another thing which is used for research purposes, it is sequencing, and it is considered as the gold standard. Sequencing is done of the ITS target. And then there is a morphological identification. In a resource limited setting, if you still want to identify fungus, you can go ahead and use LPCB, lactophenol cotton glue, make a preparation of the growth and just see the slides. I'll show us a couple of slides. This is a very lovely rhizopus. LPCB was done, and it had beautiful rhizoids, which is characteristic of the fungi. Susceptibility testing is also done for molds like aspergillus. So microbrod dilution method is used. The drugs which are tested are amphotericin B, echinocandins, azoles, and 5-fluorocytosine. The test is validated for Candida, Cryptococcus, and Aspergillus. For Mucor, we are yet to validate. Now, the most talked about diagnostic technique in today's time is molecular diagnosis. So here, what do? We detect the DNA of the Mucorales species. It is a very highly sensitive, highly specific test. So there is no chance of having a false positive in this case. The most common targeted regions are ITS, 28S rRNA, 18S rRNA, RNL gene, B gene, and cottage gene. These are the common targets which usual commercial kits would go ahead and use. The specimens which are acceptable for a Mucor PCR include BAL, tracheal aspiration, sputum, pleural fluid, paraffin embedded tissue samples, biopsy, and serum samples. So this Mucor PCR is a very big game changer if used appropriately. So this is a test which uses serum. For any other fungal diagnostic test, you can't use a serum usually. But in this case, serum really helps to monitor high-risk patients. And when we have tested on serum of patients of invasive mucormycosis, the test was found to be sensitive. It had low limit of detection and could detect infection earlier than the conventional method. So here we recommend that you screen and monitor serum of high-risk patients so that you could nip it in the bud. So now this further slides are future possibilities. These are not the ones that we are doing as of now, nor they are available a lot in the market, but this is a possibility in the future. One is immunohistochemistry using monoclonal antibodies. So it will be a microscopy again, but based on immunohistochemistry. It will be very useful if you have a smear or culture which is coming consistently negative. Then you could, there is a development of a CARD test, lateral flow immunoassay, for detection of Mucorales cell fucomenin. Like we have galactomenin specific for Aspergillus, there is fucomenin which is specific for Mucorales. And this is in research purpose and it is already tested on murine models. Let's see when it is made available for commercial purposes. There is one more test which is called metabolomics breath test. In this, we analyze the breath profile of the patient and there is a component called sesquiterpene. So this one will help us monitor response to the therapy. This is also tested only on murine model. So now we know that there are a lot of diagnostic techniques. Here I have missed upon the serology testing. So we have beta, the glucan, we have galactomenin testing. These are not diagnostic for mucormycosis. They are helping us rule out mucormycosis or maybe rule out aspergillosis. So if a patient is having aspergillosis, then these two tests are useful. And if you have a negative beta-D glucan, a negative galactomenin, then you can be more sure that it is not aspergillosis. Like we have gone through the clinical manifestations, the lab diagnosis, and everything. There are some take-home messages that I have for the public in general. As we have, at the end of the presentation, all of you must have understood that diabetes is the single most risk factor, the biggest risk factor. So regular health checkup, even if you are diabetic, even if you are a non-diabetic, screening yourself regularly for diabetes is very important. If you are a diabetic, go ahead and take good care of your diabetes. You should avoid visiting sites with excessive dust, meaning construction sites, excavation sites. And if the visit is unavoidable, wear a suitable N95. use sterile clean water for humidifiers and oxygen concentrators. In today's date and time, we have a lot of people who are using humidifiers at home, not only for COVID but a lot of other diseases. Patients with interstitial lung disease, pulmonary tuberculosis, they need this sort of palliative therapy. So it is very important that we use clean sterile water. One more piece of advice for all patients who are discharged post-COVID. Do not consider blocked nose or sinusitis very trivial, especially in context of immunosuppression, because it might be COVID. So if you have a blocked nose, don't ignore. Immediately consult your physician, trust your physician, and go ahead for the tests or go ahead for the consultation and just rule out whatever could be. Best preventive measure is environmental modification, that is reduce the risk of exposure to spores in the air. So if you have a high risk group or where you are treating high risk patients, that this ward or this floor or this this room will have patients who are suffering, who are post transplant, who are post bone marrow transplant, solid organ transplant, who are suffering from hematological malignancies, you could consider the use of HEPA filtered air homes. Preventing the accumulation of dust in the environment of houses of neutropenic patients or any immunocompromised patients. I also wish to consider that flowers and plants should be excluded from such environments. There is a myth that mucorales or mucormycosis is the black fungi. It is not. Black fungi is totally a different category of fungus which have melatonin in the cell wall. All these fungi, Aspergillus, mucor, they are hyaline fungi. So please don't call them black fungi. Medical nomenclature is very well defined for all the fungi. Mucormycosis is not contagious. A person who has mucormycosis cannot spread it to the other person. No antifungal prophylaxis. So don't ask your clinician that, I've got COVID now, should I start taking some antifungal so that I don't develop mucormycosis? So there is no prophylaxis recommended. Mainly it is all about prevention as much as you can. There are some take-home messages for my paramedical fraternity. Do not hesitate to seek aggressive investigations to rule out or diagnose. Recently, we have seen that patients come to the clinician, they say, I have a little nasal crust. So then you should not ignore. This nasal crust patient was only one nasal crust was there for which he consulted the doctor, and he was diagnosed to have rhinocerebral mucormycosis, and he had to seek aggressive treatment. So do not hesitate to seek aggressive investigations to rule out or diagnose the disease. Most important will be the correct collection of specimen. Having a specimen which is representative of the lesion. Transportation and handling is a must. Correct transportation, correct handling. Microscopy should be performed urgently. All these cases of KOH, fungal culture should be taken upon priority. Utilize the findings of routine gram stain and aerobic culture for intimating clinician for mold, if any. No antifungal prophylaxis, again I'll mention here, is recommended. No slow escalation of amphotericin B during therapy. Dr. Sura has already touched upon the diagnostics, so I'm skipping all that part. Again, aggressive infection control strategies for susceptible population at the end of patient, at the end of hospitals, and at all levels. The conclusions, early diagnosis leads to better outcomes. Higher degree of clinical suspicion is what is going to help your patient. Don't panic. Team approach works the best. Communication between laboratory and clinician is very crucial because these are high-end tests, and sometimes a lack of communication will be detrimental for the patient. Prevention is the key for this already emerging disease amid a pandemic. Thank you very much, everybody, for attending this so patiently.
Thank you, Dr. Pooja, for such a detailed analysis of the disease. And you've covered all the aspects of this disease, I'm sure.
Thank you.
Dr. Sura, we have 5 more minutes. Can we just take a few questions? Dr. Sura, could you just join in?
Yes.
Yeah, sure.
All right. So because we just have 5 minutes left with us. So a few questions like, are we seeing cases of aspergillosis and candida?
Yes.
Would you like to take that?
So we are seeing cases when so basically let's just make it very brief. Patients who have polyposis in the nose were having fungal debris within those polyps prior. We used to remove them and send them for testing. We not even bother about it. But in the current environment, any patient who has a fungal ball also caused by aspergillus is being treated as a mucor species and being given ampho. So what we are looking for is doing the typing of the mucor species. If it turns out to be aspergillus, we do the sensitivity, and if the sensitivity says anything other than amphotericin, we are giving that probably itraconazole or voriconazole and sending the patient away. Not every mucormycosis is going to be invasive mucor.
All right. Another, yeah.
I have a list of the questions that I can just cover them really fast. And Dr. Pooja, if you could
we have limited time, Dr. Sura, just 4 more minutes. So if you could
so
just
the earliest sign that patients have is a loss of sensation on the cheek because involvement of the maxillary nerve, the infraorbital nerve. The risk factors of the risk after COVID is 3 to 4 weeks post-COVID is the presentation of the patients, but the risk remains as long as the sugars are uncontrolled. Dr. Pooja has highlighted that there has to be control of sugars. It cannot be transferred from one patient to the other. It is not contagious, again covered by Dr. Pooja. Personal and community hygiene does play a very important part because it's an opportunistic fungus growing in saprophytic and dead and decaying matter. So if you keep your environment clean, you will not be exposed to that fungus. Steroids are a risk factor simply because it causes uncontrolled sugars. If the sugars are in control despite giving steroids, then the patient will not be at risk. That's the only thing. So steroids on its own is not a risk factor. Steroids causing uncontrolled sugars is a risk factor. There are no asymptomatic cases known. I mean, if you have mucor in your nose, which is invasive, it will not remain asymptomatic. And ma'am, what about the oxygen thing? Can you take that over, ma'am? Dr. Pooja? You're on mute.
Dr. Pooja, you are on mute.
Yeah. Okay. So the question says, is industrial oxygen usage to fulfill the shortage of oxygen one of the reasons? So yes, this is a speculation that industrial oxygen causes more mucosal damage, and because of that, the spores get an easy access to the respiratory mucosal lining. So yes, there is a speculation that there is no evidence-based study conducted for the same. Any other questions, Dr. Sonal, should I attend to? Because there is a big and I'm not sure.
And the last question
we have just 30 more seconds.
Okay, great. So white
just
fungus
have 30
is
more
nothing but
seconds
candida,
to go. I think
and yellow fungus is just pus.
Yeah. So, we will have a rainbow of funguses by the end of the session.
I mean, we are just running out of time, and I would like to thank each one of you for attending this session with us. And we'll be sending across some emailers with all the details. And if you have any questions, call us on 4896 9888. Thank you very much.